In Chapter 9, we are going to be discussing the principles of infectious disease and epidemiology. So there's going to be a lot of terminology associated with this chapter. So I definitely recommend that you look into some index cards and make yourself some flip cards. I know some people like to do them on the computer, but it's really great to actually have them physically with you. That way you can kind of do them like when you're waiting to check out at the grocery store, or if you're just kind of sitting there in between classes, you can just pull out those index cards and flip through them really quickly. And then also one thing to point out with index cards, if you make those and you make flip cards, take the words or the terms that you are good with out of your deck because you don't want to waste time studying on things that you already know. Okay, so we're going to go over some of that terminology in the beginning, and then you'll see some more terminology weave throughout our conversation in Chapter 9, as well as Chapter 10. We're also going to talk about some facets of disease transmission, and then we'll talk about stages of disease, and then we'll get into epidemiology essentials, a little bit about hospital epidemiology, surveillance, eradication, and then some ethical issues that we actually have to deal with when we start talking about imposing different constraints and criteria on the general public. So we're going to start with that disease terminology. So in this chapter, we're going to talk about basic terms and principles of infectious disease and epidemiology. And epidemiology basically is the monitoring and controlling of disease occurrence to promote public health. And a lot of that stems around infectious disease. So infectious disease is an illness that's actually caused by a pathogen. And we've already talked a little bit about pathogens. So pathogens are those disease-causing microbes, and they can include viruses. Prions are bacteria, protozoan, helminths, and fungi. And we see that pathogens can be further broken down into either opportunistic pathogens or true pathogens. So an opportunistic pathogen is only going to cause disease when the host is actually in a weakened state. So maybe they have a weak immune system. Individuals that are older or younger are actually considered immunocompromised because their immune system, if they're young, hasn't fully developed. And if they're older, we'll talk about this in our immunology chapters, but when they're older, you actually start to see your rate of blood cell synthesis decreases, the volume of your bone marrow decreases, and that's where blood cells come from, and blood cells give rise to your white blood cells, and your white blood cells play a huge role in your immune response. And then also your thymus gets smaller as you age as well. And thymus is the site where you actually have T cells maturing, and so your T cell output decreases as you get older as well. So there's multiple reasons why when you're as you age, you become more and more immunocompromised. Also could be somebody that's maybe on immunosuppressant drugs. Maybe they've had some kind of transplant. Maybe they're undergoing chemotherapy for cancer treatment. They would be considered immunocompromised, so on and so forth. A true pathogen is a pathogen that does not require a weakened host to cause disease. So for instance, let's say that you are going about your day and your colleague comes in and they sneeze on you, and turns out that they have the flu, and then you get the flu. So influenza virus would be an example of a true pathogen. So we can actually describe disease based on its frequency. So if we have a disease that has isolated infections in a particular population, that is considered a sporadic disease. So an example of this would be Ebola. So we see this will pop up in from time to time in various areas in Africa. The Ebola reservoir is actually fruit bats. So a lot of times we actually see villages will come out with these sporadic cases with Ebola when the villagers have actually taken fruit bats and they've cooked them because they'll eat them, and they handle the carcasses and they don't wash up properly, and or they undercook the meat. We also see sporadic cases of black plague, caused by Yersinia pestis. So Black Death, the plague, that actually is still found in the United States. And if you ever go out into the Midwest, you'll see all these signs that tell you not to touch the prairie dogs out there, because prairie dogs actually can carry the bacteria, and a flea can bite them. The flea is then infected with the Yersinia pestis that causes the plague, and then it can, if you get close to the little prairie dogs, they're pretty cute, and you want to feed them something, you get close to them, and the fleas can then pop on you, bite you, and then inject you with the bacterium. So we do see sporadic cases of the plague. Luckily, it's easy to cure with antibiotics. Back in the day when it decimated the European population and killed what I think it was 2/3 of Europe's population in the, I want to say the 16, I'm terrible with dates, I think it was the 1600s, they didn't have antibiotics. So now we do, and if you catch it early enough, it's not a big deal. We also see that we have endemic infections. Endemic infections are different types of infectious diseases that are routinely detected in a population or within a region. So an example of this would be head colds. So head colds are primarily caused by rhinoviruses or coronaviruses, and we're going to find those within the population. We had recently in the Tampa Bay area, we had an upper respiratory infection going around. So again, this head cold is kind of always there. An epidemic is going to be a widespread disease outbreak in a particular region during a specific time frame. In Tampa a little while ago, we had hepatitis A that was being detected, and so the concern was that we were going to have a hepatitis A outbreak in Pinellas County. So that's an example of how you can have this epidemic. A lot of times the word epidemic and outbreak are used interchangeably. A pandemic, a little bit different than an epidemic. It actually occurs if an epidemic spreads to numerous countries. So we actually, several years ago, saw the very short, but we saw a little bit of a pandemic occur with the flu virus. So there's different strains of flu that can spread, and a lot of times these pandemics are going to be these diseases that are highly contagious, and they're not very super debilitating, so that individuals can still travel. So a lot of times these pandemics spread because people will still get on a plane to travel, or they'll get in their car and they'll drive across state lines, so on and so forth, and they will start to spread these particular diseases from one area to another. We see that there are emerging and re-emerging pathogens, and these ones are especially likely to cause epidemics or pandemics. So an emerging pathogen are going to be things that are newly identified, and also maybe they're pathogens that previously caused only sporadic cases. So Zika virus is a prime example of that. So we used to see Zika sporadically in South America, and now we've seen that the geographical range for that has spread. Re-emerging pathogens is an infectious agent that was actually under control, but now it's resurfacing. So prime examples of this are antibiotic-resistant bacteria, more specifically Mycobacterium tuberculosis. There are several strains of Mycobacterium tuberculosis that are multi-drug resistant strains. So this used to be controlled, albeit it was a lengthy antibiotic treatment, but it used to be controlled with antibiotics. Now that same treatment is not rendering effective, so we're seeing these re-emergent cases occurring. We can also describe disease based on how it's spread. So if you have something that is transmitted from human to human, it is considered a communicable disease. So an example of that would be the influenza that I mentioned, or maybe flu, like I mentioned, a head cold. Contagious diseases are communicable diseases that are easily transmitted from one host to the next. So very easy to get these. So an example of this might be measles. Measles are highly contagious. Again, the flu can be considered a contagious disease because it's relatively contagious. Norovirus. There's a lot of different things that go into play with something being a contagious disease. So it's not just how easily it infects that individual, but a lot of times it has to do with how much of that infectious microbe is being released from the infected individual. So the example of norovirus. So people can excrete up to like 10 to the 10th virus particles per gram of feces, and vomit, like pretty high concentrations of these virus particles when you're actively infected. So, and the infectious dose is relatively small, so it's like 1 to 10 viral particles. So you get anywhere near somebody that's, undergoing vomiting from norovirus, if you've ever had it, you know what it's like. It's kind of projectile vomiting. Then high likelihood that you're going to get that because it is so contagious. We also have what's called zoonotic diseases. These are spread from animals to humans. It's kind of easy to remember because you can kind of think of zoos. Zoos house animals. Humans go to see animals at zoos, so you can see that connection there. Zoology is the study of animals. So many zoonotic diseases actually are non-communicable diseases, so they do not spread from person to person. So an example of this would be Lyme disease. So Lyme disease, a tick bites a deer that's infected, and then that tick will then bite a human, and it will spread the Lyme disease to that human. But whoever's around that particular human is not going to then get Lyme disease from just being around that human. So an example of non-communicable disease. We can also describe an infection based on how it's experienced by the actual hosts. So if you have somebody that's experiencing an active infection, that patient is considered symptomatic, and that person will then have symptoms, which makes sense, but also these things called signs. So signs and symptoms, and there is a difference between the two. So signs are basically going to be something that are objective indicators of disease that actually can be measured or verified. So an example of this would be if you walk into the doctor and you're like, oh, I don't feel so good, and I think I have a fever, and the doctor takes your temperature and actually does, in fact, confirm that you have a fever. So that's something that's measured. Also a rash, so something that can be observed, or if you see like blood in the stool, well, that's not supposed to be there. So that's again a sign that can be observed by a physician or yourself. Symptoms are something that's sensed by the patient. So these are subjective rather than actually precisely measurable. So this is when you wake up and you're like, oh God, I just don't feel good. Well, you can't really go to the doctor and say, hey, grab your don't feel good measurement tool and rate me based on the don't feel good scale. So that's actually something that you physically feel, but it cannot actually be measured. Pain is another example of that. And then tired. So, oh, I'm so tired. You can't really measure that. Nausea is another good one. So nausea, you're not actually physically vomiting, but you feel like you are nauseous. So those are examples of symptoms. So you feel them, but they can't actually be measured. We do see patients experiencing latent infections. So those infections that are usually asymptomatic, and they'll show no signs or symptoms. But that does not necessarily mean that they are not infected. And we'll talk a little bit more about that a little bit later on. Infections are sometimes characterized by onset and duration as well. So we can call infections acute diseases or chronic diseases. So acute diseases will have a very rapid onset and progression. So again, going back to the head cold. So you come in to work and you see somebody sneezing next to you and you're like, oh crud. And then 2 to 3 days later, you then have a head cold. So that's an acute disease. It lasts for a very short amount of time, maybe about a week, and then you're all done with your head cold until you get infected with a different strain of that particular virus that causes another head cold. And hopefully that's like up to or over a year later. Chronic diseases have a little bit slower onset and a little bit slower progression. So they tend to be experienced for an extended or a longer period of time. So an example of this would be some type of hepatitis diseases. They tend to be slow and have a slower onset and progression. Also, we talked about those infectious proteins. Those tend to have a pretty slow onset and pretty slow progression. All right, let's talk a little bit about disease transmission now that we've characterized diseases in a variety of ways. So we do see that infectious disease caused by pathogens, and again, those can be true pathogens or opportunistic pathogens, and those pathogens are going to come from different sources. So our sources are going to be what actually disseminates or spreads the infectious agent from the reservoir, so where it kind of resides and lays low until it gets to a host and then can replicate and spread. So we have two different sources. We have endogenous sources and exogenous sources. So an endogenous source is when the pathogen actually comes from the host's own body. So maybe we have disrupted microbiota, and then you have some opportunistic pathogens that live in the area, but those opportunistic pathogens are usually kept in check by the microbiota. But now, since those normal microbiota aren't there, the opportunistic pathogens then have the opportunity to grow and establish an infection. So an example of this would be yeast in the vagina. So there is a low level of yeast in the vagina, and it's usually kept in check by the lactobacillus that's in the vagina, and that secretes a acidic pH and keeps that yeast at bay. Well, if you take antibiotics, you kill off that lactobacillus, and basically there's no competitors then for the yeast in the vagina, so that can lead to a yeast infection of the vagina. Also, we can have misplaced normal microbiota. So maybe on the skin you have some staph and it's not going to cause any problems because it's just laying there on the skin. But if you maybe get a cut or you have surgery and then that skin wasn't cleaned off properly prior to that cutting of the skin, then the bacteria gets into that surgical site and then it's into the bloodstream and it can infect tissues and all that fun stuff. So it can lead to a variety of different bad health outcomes. Exogenous sources are when the pathogen is external to the host. So maybe it was in the environment, or maybe it was a zoonotic disease transmitted via or to people from an animal, or maybe it was a communicable disease where another human transmitted it. There are a variety of modes of transmission for infectious agents, but they're generally categorized as transmission through direct contact or indirect contact. So just to give you guys some examples of direct versus indirect contact. Direct contact is we can have person to person. So things like saliva, touching, intercourse, maybe sneezing, things of that nature. Animals, when animals come into direct contact with a human, you can have either a bite or a scratch, and then that can lead to the transmission of zoonotic diseases. We can also have direct contact with the environment. So maybe the pathogen actually resides in an environmental source. So maybe you have you've gone swimming and there's a large concentration of Pseudomonas within the actual swimming pool. Somebody didn't properly chlorinate it, and then you get swimmer's ears. And then we can also have another form of direct contact or direct contact transmission is vertical transmission from mom to baby. So this can happen a couple different ways in utero, and sometimes that's just a fancy way of saying that it crosses over the placenta. So syphilis can do this, HIV can do this. I do want to say that that does not happen 100% of the time. For HIV, I know it's around 20% of the time it can cross the placenta. Vaginal delivery, we can have group B streptococci infecting baby. Gonorrhea can spread to baby's eyes and cause some pretty severe infections. And then also another example of vertical transmission is through breast milk. So HIV can actually be transmitted through breast milk. Okay, now indirect contact transmission occurs if we have something that's airborne, so maybe airborne particles carry the pathogen. I do want to point out that as far as there's a little bit of a gray area between direct contact with airborne and indirect contact with airborne. So it's said that if you I forget the exact footage, but I'm not going to make you guys memorize this, but I think it's like 5 feet or more. If the disease can spread, then it's considered indirect and airborne. But if it's within like 5 feet of the person and they sneeze, then it's considered direct contact. And that's because there are some viruses that when you sneeze, they can be spread in the droplets that you sneeze, but as soon as those droplets start to dry out, the viruses actually start to dry out and they no longer then are infectious. But there are other viruses that in bacteria that if you sneeze, that it will spread via the air, but then they are not inactivated when they start to desiccate a little bit, so they will survive a little bit longer. So those then would be considered the airborne indirect contact transmission. We also have vehicle transmission. So vehicle is when the pathogen is actually introduced to a host through contact with contaminated objects. And then we can have vector indirect contact transmission. And there's two forms of this. We actually have the biological form and the mechanical form. So the biological form is when the actual vector, vector being like a tick, mosquito, deer fly, biting fly, kissing bug. There's a variety of different vectors. We'll talk about them when we get into the actual different types of diseases. But the actual vector has insect vector plays a role in the actual pathogen's life cycle. So an example of this would be malaria. So malaria has a very complex life cycle, but it actually undergoes a maturation process within the mosquito's gut, and then it moves up into the salivary glands of the mosquito, and then it's injected into the human. Now, we also have vector transmission where it's actually mechanical. And mechanical basically means that the pathogen hitches a ride on the actual insect, but does not actually complete part of its life cycle in that actual insect. So an example of this, I don't know if you guys remember a while ago, bed bugs were like running rampant in the New York area. And then people were starting to get like MRSA infections more frequently up there. Well, it turns out that the bed bugs were actually carrying the MRSA with them. And so the MRSA was being transmitted mechanically via the vector. Now, just a little, you guys don't need to know this for the test, but some fun info for you. I'm pretty sure you all have heard of the 5-second rule. Well, there have actually been studies on the 5-second rule to see if it does in fact work. Like, if you drop something down on the ground, if you've never heard of the 5-second rule, this is how it works. If you drop something on the ground, food product, you go, oh, 5-second rule, and you pick it up really quickly, and then the saying is that you can eat it. So in 2002, there was a study that was done where they actually took some tile and they inoculated it with E. coli, and then they did brief exposure of various food products, and they found that yes, the food products became contaminated with E. coli. However, they went and then looked at public flooring, and they found that there was no real significant evidence of pathogen contamination on public flooring. A lot of bacteria, but most of it was soil-based bacteria. There was another study I found done in 2006 that where they took salmonella and they inoculated it on different types of flooring, so wood, tiles, nylon carpet, and they let it sit for 8 hours. And then they put bread and bologna on it, and they found that the bread and bologna did become contaminated in less than 5 seconds. So the moral of this story is that the 5-second rule is a farce. Bacteria can still bind to your food within that 5 seconds. So if it's there, it might bind. So I would not recommend doing that. I would recommend adopting a very cute puppy and allowing the puppy to clean up after you if you are a person that habitually drops food on the ground. Or get yourself a broom and a dustpan. Another one, double dipping. Oh gosh, I'm terrible at double dipping, but I always make sure that it's my own. I take a little cup to myself and I double dip myself. I mean, like, if you get a big old chip, like Chili's, you know how the big old chips? Yeah, the big old chip, and you just get like a little corner with some salsa. Well, you want salsa on the whole chip. So yeah, I double dip, whatever. But I don't do it at parties, I swear. So Mythbusters actually did an episode on double dipping, and they actually found that most salsas and dips actually already contain bacteria, which makes sense because the foods that we eat are not sterile. And when you actually take a bite out of like a chip or a cracker, think about it. When you bite down on it, the parts that are actually hitting your mouth are pretty much staying in your mouth. So it breaks off, and usually that's the part that has not touched your mouth. So they did find that in some cases it would only add a few more microbes than what was already there. And then also, there's been studies that show that salsa, it's got such an acidic pH that there's really a negligible increase. That being said, if you have like an open wound or like a cold sore, definitely don't recommend double dipping. So the moral of that story is that if you go to a party and somebody accidentally catches you, or you accidentally double dip because you're not thinking, you're like, oh, I thought I was at home, and somebody like calls you out on it, just be like, well, listen here. I learned via a myth, don't use my name, say Mythbusters, that it wasn't that big of a deal. All right, so let's move on to stages of disease. So once a pathogen makes contact with a potential host, its job then is to try to establish infection. And some pathogens are better at doing this than others. So we can actually use terms to describe that. So infectivity describes how good an infectious agent is at establishing an infection. So if something has a high infectivity, that means they're pretty darn good at establishing infections. The infectivity is based off of virulence and pathogenicity. So virulence describes the severity of disease following infection, and pathogenicity is the general ability of an infectious agent to cause disease. So these things are kind of go hand in hand. And we will talk a little bit more about this later on, but when we look at virulence, we actually see that virulence is based on the presence of what's called virulence factors. And there's a variety of different virulence factors, and we're going to talk about those a little bit later on. But there are very discrete proteins and enzymes called virulence factors that allow these things to be more virulent or less virulent, and then have more pathogenicity or less pathogenicity. So just in general, let's talk about the progression of infectious disease. So in general, and again, not every disease follows this rule, and we'll talk about some exceptions as we go through, but in general, there are 5 basic stages of disease. You have the incubation period, the prodromal phase, the acute phase, the period of decline, and then the convalescent phase. So let's go through each of these. The incubation period, so you're going to see a graph on each of these following slides, and I just want to kind of point out what's going on in this graph. So on the x-axis we have time, arbitrary time, because the amount of time is going to depend on the actual type of disease. And then we have this arbitrary level of pathogens. So we'll see initially they'll start off low, they'll get high, and then they'll start to come back down. Hopefully, if your immune system is doing its job, they'll come back down excuse me, and then the patient will recover. Okay, so let's start with phase 1, stage 1. This is the incubation period. So this is the time between the exposure to the actual, excuse me, oh my gosh, excuse me, I'm having sympathetic infection. The incubation period is the time between infection, the exposure to the actual infectious agent and then the development of disease. And this could be anywhere from hours to years depending on the actual disease. And then we start to see this prodromal phase. And this is when the patient starts to feel run down and they might start to exhibit mild symptoms. You might even have some signs starting to develop. So I like to think of this in terms of a head cold because a lot of people have experienced a head cold before. So this is usually when well, let's go back to incubation period. Incubation period is when you walk into work and you see Bob and he's sneezing and his nose is all runny and you're like, oh, crud. And then you realize that you went to use the copy machine and Bob had just used it before you. And now you're touching everything he's touching and you wipe your nose with your hand and you're like, oh, crud. I've definitely been exposed. And then phase 2, the prodromal phase, is when you wake up a couple days later and you're like, oh, God, I'm just so tired. I know I got 8 hours of sleep last night, but I am starting to feel crud. I'm starting to feel some pressure develop in my head. That's your prodromal phase. Then we enter into the acute phase. This is when you got those full-blown classic symptoms of the disease. So for the head cold, you're sneezing, maybe you have some sinus pressure, your nose is running, your throat might be a little sore from that postnasal drip. This is known as a symptomatic case or a clinical infection. And this is usually the peak of the disease. Then we start to see, again, assuming the immune system's working properly, we start to see the pathogen replication decreases, the immune system starts to kick in and starts to limit the growth of that pathogen, and then ultimately starts to kill off that pathogen. You start to feel a little bit better. Maybe you're not quite there. You're like, ugh, like I feel like I have a little bit more energy now. I feel like I'm functional. Still got some snot coming out of my nose, but I can still keep on going. Now, your book puts this. It's not funny, but it's kind of funny the way it's stated. Not all patients are going to experience this phase because some actually die depending on the type of disease that they're experiencing. And then some patients, because they start to feel better in this period of decline, if they're actually on medication, specifically antibiotics, a lot of them will stop taking, well, not a lot of them. In the past, we have actually seen trends where patients will stop taking their medication because they feel better. Now, this is, and we'll talk about this when we get into talking about antibiotic resistance, but this has bred a lot of antibiotic resistance because basically, if you stop taking your antibiotics before the end of the regimen, what you've done is basically expose your bacteria that cause an infection in your body to sublethal doses of antibiotics, and potentially you've added selective pressure on them, and then allow those that are mildly resistant to the antibiotics to then survive, thrive, and divide. So not a good thing, and always should remind patients, even if you start feeling better, keep taking that medication until the prescription is done. And then we enter into the convalescent period, and this is when you have elimination of the pathogen from the body. So your patient recovers. In some cases, do want to point out that the pathogen may be kept latent in the patient. So an example of that would be like a cold sore. So you get a cold sore, the acute phase is when you actually have the sore. The period of decline is when it starts to heal, it gets smaller, and then the convalescent phase is when it's gone, but we actually see that the virus is still in the body. And again, we'll talk more about that when we get into our disease chapters. Now, we do have some pathogens that infect the host, but they cause what's called an asymptomatic case. This is also known as a subclinical case. So this is when the symptoms are either mild or non-existent, so the person doesn't even know that they're sick or know that they're infected. So with that, we actually do see that the prodromal phase and then the acute phase might go unnoticed, and in some cases, the actual pathogen might still be increasing in numbers, so increasing in the actual concentration. So the table here shows you some examples of this. I just want to give you a common example, HIV. So HIV starts off pretty much asymptomatic, and it isn't until later on in the disease, as it progresses, that the individual starts to experience some of the signs and symptoms associated with an HIV infection that then progresses into AIDS. So that's going to be our chronic infection because it lasts so long, and then again you don't have that characteristic increase and then decrease. We actually see that there's this spike of the viruses upon initial exposure, and then over time you'll see an increase of the viral particles in the system. Okay, sometimes our host harbors a pathogen indefinitely, so they might stay with the actual host forever. That pathogen might be able to exist in a dormant or latent state in the host and reactivate later. So again, cold sores, genital herpes are examples of this. If that happens, we have what's called a chronic carrier. So a chronic carrier can remain asymptomatic for long periods of time and then have these reemergence of the infection. So they'll actually have that acute phase, and then they'll have the period of decline, convalescent, and then they'll have the acute phase again. So their stages of infection might look something like this over time. Now, we do see that asymptomatic carriers can harbor certain pathogens for extended periods without actually ever experiencing symptoms. So you might have somebody that actually is secreting the actual pathogen but never experiences the symptoms. So you might see something like that for their actual level of pathogens. So again, this you guys don't need to know for the test, but just an FYI, like to kind of tie in an example of a chronic carrier that was asymptomatic. Typhoid Mary. I don't know if you've ever heard the story of Typhoid Mary, but Typhoid Mary was actually Mary Malone, and she actually worked as a cook in homes. So she was a personal cook. And what happened was in the area where she worked, families were coming down with typhoid fever. And so one of the families that she worked with, um, they wondered because a large percentage of the family members, as well as some of the guests that had come over for a dinner party, had gotten typhoid fever. So they actually hired a private investigator to figure out what was going on and try to figure out where they all had gotten sick from so that they could prevent it from happening. So the guy came in, super, he came in and he compiled a 5-year history of Mary's employment. And what he found was very interesting. He found that 7 of the 8 families that she worked for actually had developed typhoid fever. So he asked her, he said, "Hey, can you give me some urine samples and some stool samples?" So typhoid fever, in case you don't know, it's actually spread by salmonella. And it's spread fecal oral route, so it's excreted in the feces. So he asked for a stool sample from Mary, and she said no. And the reason she said no is because she wasn't sick. She did not have typhoid fever. She's like, why should you suspect that I'm the one transmitting this to everyone because I'm not sick? So she refused to do this, and they actually quarantined her. So they quarantined her from 1907 to 1910. And turns out she actually rarely washed her hands. She said she felt there was no need because she wasn't sick. And when she was in quarantine, they actually took samples by force. And what they found was her gallbladder actually was contaminated with salmonella. So that was one of the reasons why she wasn't experiencing any of the symptoms, because the salmonella wasn't infecting her intestinal tract. So because it wasn't infecting her intestinal tract, she wasn't experiencing any of the signs or symptoms. So it was basically just replicating in her gallbladder and then being released in her feces. And she wasn't washing her hands after she went to the potty. And so she'd go in there and cook. And guess what? She had feces hands. And so she was cooking with feces hands and contaminated everybody's food. So basically, they said, okay, we will release you from quarantine if you allow us to extract your gallbladder. And she said, no, not going to let that happen. Which, in her defense, I mean, if you think about back then, surgical procedures, not as advanced as they are now, and infection rates relatively high. So there was pretty solid chance there was a mortality rate associated with that surgery. She also refused to give up cooking because that was her profession. That's how she made money. So eventually, after 3 years, she said, fine, if you guys will let me out, I will wash my hands before handling food and I won't cook for anybody. So she was released and she actually went and started doing laundry. Well, guess what? Laundry wasn't as lucrative as cooking. So she said, screw this. I'm going to change my name and I'm going to start cooking again because I want to make some more money. Well, guess what? She spread illness and death. In fact, in 1915, there was a serious epidemic in this hospital for women. There were 25 cases of typhoid fever and 2 deaths. And guess who caused them? Well, Typhoid Mary did. So in 1915, she actually was quarantined for life on this. I forget the name of the island, but island in I believe in New York somewhere. And she ended up working in a laboratory while there. So again, this shows you, one, how you can have these carriers, and then two, we're going to talk about quarantine. Could you imagine trying to quarantine somebody for life nowadays? It would not go over well, right? We can barely get people to stay on vaccine schedules. So just thinking about we're going to talk about the ethical issues associated with public health and trying to implement public health measures. So thinking about that and thinking about how far we've come. So with that, again, you guys don't need to know the story for the exam. I just wanted to share that with you. So with that, we will talk about epidemiological essentials and hospital epidemiology in our next segment.